welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. I'm John Vasallo, managing editor of the series here at Elsevier, and for our 13th podcast, we'll be discussing the July 2024 issue devoted to contemporary management of esophageal and gastric cancer. As stated in the preface, the ecosystem surrounding the management of esophageal and gastric cancer is rapidly changing with the addition of new therapeutic options and innovative surgical techniques. This special issue focuses on many important diagnostic, therapeutic, and operative components within this ecosystem. In this podcast, we will discuss some of these new options and techniques with 4 articles from this issue of 12. Leading the discussion will be our consulting editor, Dr. Tim Pollack, Professor and Chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editors of the Esophageal and Gastric Cancer issue, Dr. Robert Merritt, the Adnil Day Designated Professor and Director of the Division of Thoracic Surgery at the James Comprehensive Cancer Center in Columbus, Ohio, and Dr. Smita Sihag, Assistant Professor in the Department of Surgery at Memorial Sloan Kettering Cancer Center in New York, New York. Welcome to all 3 of you, and over to you, Dr. Pollack.
Thanks, John. Really excited to be with Dr. Merritt and Dr. Seahog today to talk about this great latest addition to Surgical Oncology Clinics of North America. There's been a lot of exciting developments in the treatment of patients with esophageal and gastric cancer over the last number of years, so I think it's only appropriate that we have an updated volume on this topic. I thought we'd kick off maybe talking about some of the technical advancements when it comes to patients with esophageal cancer. I wanted to maybe chat with you, Dr. Merritt, a little bit about the paper that Dr. Stock and colleagues wrote on robotic-assisted Ivor-Lewis esophagectomy. I don't want to date myself, but I can remember when I was a resident, esophageal surgery was very, very morbid surgery, open surgery, thoracotomy. Really, my impression is that the introduction of the robot and robot-assisted surgery has really dramatically changed the continuum of care for these patients. So I was wondering if you could provide us maybe a little bit of history and context of pre-robotic surgery, and then chat with us a little bit about how robotic-assisted esophagectomy has really changed the experience for patients with this disease.
Oh, sure, absolutely, Tim. No, you're correct. I can remember when I was training, I performed these operations primarily open with a thoracotomy and a laparotomy, both at New York Hospital, and actually spent time at Memorial Sloan Kettering as well, and then ultimately Massachusetts General Hospital. I think back then, we would routinely admit these patients to the ICU. Dr. Seahog can also support this claim that, a lot of these patients, the complication rates are higher, I think, with open surgery, particularly the thoracotomy really does compromise post-op pulmonary function and is quite a bit of a challenge, for patients to recover, especially older patients with medical comorbidities like COPD. I think the risk of pulmonary complications are a lot higher with the open thoracotomy. I think with the advent of minimally invasive surgery, particularly robotic-assisted thoracoscopic approach, is certainly less invasive and certainly does allow patients to recover from this big operation a lot easier than with the open thoracotomy.
The paper does a really nice job of highlighting some of the specifics just around even how you position the patient in the operating room, and then the kind of conceptual steps, procedural approach to the robotic-assisted Ivor-Lewis. And I wonder if, Bob, you could just take us through kind of like some of the highlights of what you're thinking about when you bring the patient to the operating room. How do you position them? And then what are some of the kind of seminal steps of this procedure for our listeners?
Oh, sure. So the Ivor-Lewis esophagectomy, whether it's open or minimally invasive, is conducted essentially the same way. It's a 2-incision operation. The first component is called the abdominal phase, where we mobilize the stomach, create a gastric tube, which will serve as the replacement for the distal esophagus. And often we will place a J tube during the abdominal phase. And these patients are positioned supine. The most important, I think, aspect of the abdominal phase is to not injure the right gastroepiploic arcade, which essentially is the entire blood supply to the gastric conduit. So really, in my mind, that's the most important, aspect of the abdominal phase of the operation. And then upon completion of the abdominal phase, we then position in what's called the left lateral decubitus position with the right chest facing upward. And that's essentially we access the right thoracic cavity to complete the mobilization of the esophagus. And then really the most important part of the thoracic phase is the esophageal gastric anastomosis, which is in most cases performed with a circular stapler, but it can be performed either hand sewn or with what's called a hybrid stapled and sutured approach. And the robot really lends the opportunity to perform all three of these anastomotic techniques, whereas with traditional thoracoscopic surgery, most of these anastomoses were stapled.
And then with regards to patient selection, is there any role for open Ivor Lewis or even, I remember I trained at that school up north where THE, transhiatal esophagectomy, was quite popular. So when selecting patients, who are appropriate for a robotic approach, and are there any patients that you need to do an open Ivor Lewis or even a THE?
So great question. So I think for most cancers that are at the gastroesophageal junction or distal third of the esophagus, I think we can easily perform these operations with an Ivor Lewis esophagectomy. And most patients are candidates for the robotic approach unless they've had previous surgery with extensive adhesions. I think it would be a challenge to do these operations robotically. For the more proximal esophageal cancers in the mid esophagus, where we may need to get a larger, more proximal margin on the esophagus, we may have to consider a transhiatal approach or what's called the modified McEwen, where we perform the anastomosis in the neck as opposed to the thorax.
And then finally, Dr. Merritt, I was wondering if you just comment on what are some of the pitfalls? You obviously have been doing this for years. You're extremely experienced, but maybe for some of the more junior surgeons, what are some of the things that they should know about or anticipated, tricks of the trade, pitfalls, or even early postoperative complications that one should be mindful of and vigilant and making sure they don't miss?
Sure. And I think, obviously, there are, difficult situations, particularly patients that have high BMIs. I think those operations are quite challenging to perform minimally invasive. So in those particular cases, it may be prudent to perform those operations with an open approach where the operation may be a lot faster and easier to perform. In terms of post-op complications, I think the anastomotic leak is the most feared complication. Um, in some circumstances, it may be hard to clinically detect a leak, but when they do occur, it's important to intervene quickly with either endoscopic stenting or reoperation. Sepsis is a challenge in these patients, so it's important to intervene quickly.
That's great. Well, with that, I mean, I'd like to pivot maybe away from technical advances to maybe some translational scientific advances in understanding the underlying biology of esophageal and gastric cancers. And for that, Dr. Siag, I'd like to maybe pick your brain a little bit about the paper by Dr. Hompe and Saktiva on translational science for esophageal and gastric cancers. And I was wondering maybe if you could just provide us just a brief overview of what you might consider some of the seminal advances around understanding the underlying, pathogenesis of these diseases, maybe emerging molecular markers, role of ctDNA, things like that.
Great. Thank you, Dr. Pollack. Traditionally, and I think a lot of institutions and even a lot of surgeons are kind of still stuck in the mindset of the Dutch cross trial, which was published, about 15 years ago almost, where, really the paradigm for esophageal adenocarcinoma or squamous cell carcinoma was chemoradiotherapy followed by surgery. And that was about it. Finally, I think, some years later, the needle is finally starting to move on this disease in terms of how we think about it biologically. The Cancer Genome Atlas defined 4 different subtypes, including MSI, EBV, SYN, and genomically stable. And basically, that's been sort of the starting point for further translational work in this area, where we now are exploring new targets, in particular, such as HER2, VEGF, and now up and coming Claudin 18, which is an emerging target. And some of us are working on some other possible targets, such as MDM2. The other part of it is also, changing the paradigms for neoadjuvant therapy, moving more towards more aggressive chemotherapy and systemic control in certain tumors, moving away from, radiotherapy possibly, and also finding a role for immunotherapy.
I thought one interesting aspect of the article by Hompi and Sakdeva was their discussion around organoids and biobanks, and using patient-derived organoids perhaps as a predictive tool to model treatment responses, and also perhaps to develop a more personalized oncologic approach using organoid-derived models, perhaps as a screening for sensitivity around different, therapeutic agents to tailor the therapy to the patient. And so I was wondering if you could comment on that. Is that still theoretical? Is that ready for prime time? Is this something that you use in your practice? Where does that stand?
Yeah, not ready for prime time quite yet. So these are a few things that we've learned. Number one, esophagogastric cancer has not had a great model system to use to test therapeutic approaches. The mouse models are, not particularly robust. They're okay. Patient-derived organoids have definitely provided a viable new model system whereby the organoid really closely mirrors the parent tumor in many specific ways in terms of its genomics and heterogeneity and so forth. So I think the model system is great. In terms of where we are, I'd say roughly 50% of organoids actually take and grow after collecting them from surgical specimens in this cancer type. Colorectal and others are far more stable than esophagogastric. Still trying to figure out why that is. Most of the surgical tissue we get is pre-treated, so that does present an additional challenge in making an organoid. In terms of getting pre-treatment tissue for organoids, you got to get it from endoscopic biopsies, and you can imagine how many you have to collect there to make an organoid successfully. And then the other thing that we're finding is that these tumors contain a lot of other types of cells in terms of inflammatory cells, stromal cells, et cetera, that basically present an additional challenge in growing an organoid from a earlier stage tumor. The most successful organoids actually grow from tissues taken from metastatic tumors. And so the idea at this point that we can, endoscopically collect tissue from a patient, grow an organoid, and get real-time treatment data from that organoid and go back and treat the patient, we need to hone this technology a little bit better before we can get to that phase. In terms of how we're using them, I'm using them in my laboratory to test new targets. and new therapeutic approaches to try to design clinical trials. I think that's the primary role of this technology right now. Hopefully, that'll only get better.
That's very helpful. One other topic that was discussed in this chapter was circulating tumor DNA. And similar to my question around organoids, I was wondering if you could comment around how you use circulating tumor DNA in your clinical practice. And for the practicing thoracic surgeon, what do they need to know about ctDNA? And is it ready to be used in prime time, either in the preoperative setting or postoperative setting, to inform whether someone needs additional systemic chemotherapy? So in other words, if someone's ctDNA positive preoperatively, they get neoadjuvant chemotherapy, that you do your surgery on them, negative margins. Postoperatively, they're ctDNA negative. Should they be receiving additional systemic chemotherapy, or do we have high enough confidence that maybe they don't need additional chemotherapy? And then also, do you routinely use it in your surveillance? In addition to getting follow-up imaging, should we be routinely checking ctDNA in postoperative surveillance and then tailoring our post-surgical therapy based on ctDNA presence, absence levels, etc.?
Yeah, great questions. Once again, the technology, the sensitivity of this technology, most assays, and I can talk about a few, whether it's Max Dean's assay or the Signatera assay, or even our homegrown MSK Access assay at our institution. Basically, the way I see the role of this technology right now is it helps us the most right now in terms of detecting progression and recurrence. The idea that it can detect, minimal residual disease, microscopic disease, pathologic complete responses, things like that, really difficult to get to that level where it's going to be reliable, for clinical decision making. In the baseline setting, if you do pick up mutations, you can often track them throughout the patient's treatment course to see how they're responding. If there's a surge, you can be pretty certain that patient has progressed on therapy. If they go to zero, which actually does happen often, it's anyone's guess, really. They probably responded to some degree. Did their cancer entirely go away? Not likely. After treatment, so making a surgical decision based on that, that's sort of a no-go right now. Then you do surgery, then you check it again, it's still zero. Okay, that's that. And then say it is positive, is there a role for adjuvant chemotherapy? It hasn't been proven yet. As such, the benefits of adjuvant chemotherapy in this cancer type haven't been proven. Some retrospective data has shown some benefit, but nothing prospective to my knowledge. And then for surveillance, Max Dean's group showed that a positive ctDNA result could anticipate recurrence by about 3 to 6 months in comparison to imaging. So certainly some benefit there, though some argue why even bother looking if we don't have great options for people who do have recurrences. So it still remains controversial, but positive results are much easier to interpret than negative results. Negative results wouldn't base any clinical decisions on those.
Thank you. So that might provide a segue into the next topic I wanted to chat with you about was, are there emerging therapies for people who have recurrent disease or advanced disease? And may that therapy be related to immune therapy, immune checkpoint therapy? So this is a topic that Dr. Sakdeva touched on in their article, and then was really examined more in depth by Dr. Saeed and colleagues in the paper that was completely devoted to immune checkpoint inhibitors for esophageal carcinoma. So I was going to ask if you could provide maybe just an overview of immune checkpoint inhibitor efficacy based on some of the recently published clinical trials, and maybe also inform us not only about your thoughts around their efficacy, but whether there are predictors or biomarkers of who may respond versus who might not respond. Because it seems to me sometimes the effect gets washed out because you have responders and non-responders, and then it's kind of like regression to the mean. But if we can identify who has the highest potential to respond from these immune checkpoint inhibitors, there's probably a subset that would derive potential benefit. So where does this stand relative to esophageal carcinoma in 2024?
Yeah, sure. So immune checkpoint inhibitors have become part of the standard of care for advanced and recurrent esophageal cancers. So FOLFOX and nivolumab has become the standard regimen, certainly more effective than chemotherapy alone in adenocarcinomas, to the point that we are now considering surgery in some people who've had excellent and durable responses. In terms of the neoadjuvant setting, the role of immunotherapy is not clear in the majority of patients. There hasn't been, I'd say the benefit has been pretty modest in most trials. There is a trial upcoming, Matterhorn, which will read out soon in terms of chemotherapy plus immunotherapy in the neoadjuvant setting. We did also a trial of neoadjuvant immunotherapy plus chemoradiotherapy and saw better pathologic major response rates, not necessarily better pathologic complete response rates in this cancer type. So certainly could be a more well-defined role in the neoadjuvant setting. And then there's the adjuvant setting where we have probably the best data at this point justifying the use of immunotherapy in both adenocarcinomas and squamous cell carcinomas, where all patients with residual disease now receive adjuvant immunotherapy for up to 1 year, which has shown better improvements in disease-free survival. In terms of biomarkers, I think what we've learned is PD-L1 expression, while we do test for it routinely, is not a great biomarker for response. For the best biomarkers are tumor mutational burden as well as MSI status. Unfortunately, having a hypermutated tumor or an MSI high tumor in esophagogastric cancer is not that frequent. It could be about 5% in esophageal cancers, upwards of maybe 15 to 20% at most in gastric cancers. So those are good biomarkers for response, but just infrequent. In terms of the rest of the population, I think we still have a long way to go to try to figure out who's going to respond and who actually benefits. At this point, almost everybody gets it at some point in their treatment course.
Yeah, that's one thing I was surprised about as a non-esophageal surgeon was the low prevalence of MSI tumors in esophageal cancer. I mean, I found that surprising. As I read the paper, as you noted, like 5%, 8%, in some series, like only 1 or 2 patients were microsatellite high, and the overall tumor mutational burden was relatively low. Do you have any insight on that? I mean, that just seems somewhat surprising to me. I don't know if there's been further work done in this area to help explain that, or why is that the case in this group of patients?
So I guess the lowest rates of MSI high are in the lower esophagus. As you kind of go towards the GE junction and the stomach, you're getting higher and higher rates of MSI high tumors. In terms of the pathophysiology of those lower esophageal tumors, many at this point are arising in the background of Barrett's esophagus, and many are characterized by what we call ability, which is a very aggressive molecular subtype. There is some work out there as to the predilection of Barrett's tumors, that are causing P53 mutations and then are sort of going towards chromosomal instability. I think that pathophysiology being the dominant one is why most of those tumors are actually chromosomally unstable. In terms of what the pathophysiology is of how or what cell types or precancerous lesions could lead to MSI high tumors. I think we know less about that, but clearly in this Barrett's P53 SYN pathway is dominant in the lower esophagus, and that probably has something to do with it.
Yeah, that's fascinating. That's very, very interesting. Well, thank you, Dr. Seahag. I wanted to now maybe transition back to Dr. Merritt. We've been talking about some of the technical aspects and some of the translational and new therapeutic aspects that really drive outcomes for patients who have esophageal and gastric cancer. But we know more and more that there are other determinants of healthcare outcomes, and in particular, social determinants of health can be amongst the most important factors that drive outcomes for patients with cancer. So I found the paper by Dr. Bonner and Dr. Edwards that looked at the impact on racial disparities and social determinants of health on esophageal and gastric cancer, particularly interesting. So, Dr. Merritt, I was wondering if you could comment a little bit about, what specifically around esophageal and gastric cancer should we be aware about relative to racial disparities and or social determinants of health that may be unique or specific to this disease compared to other types of cancer?
Yeah, no, I think the article was, very comprehensive and, really shed light on, how the social determinants of health really, drive, the disparities that we see in outcomes for patients, African American, Hispanic patients. I think, they really focused on disparities in, like the risk factors, such as one example is H. pylori incidence is much higher in Black and Hispanic patients. It's easily eradicated, with antimicrobial therapy. However, the detection rates and testing is very low. Therefore, this is a missed opportunity to really, drive down the incidence of cancer in the early stages. The other areas are, access to high quality care. If you look across the spectrum of, African American patients, if you look at the rate of, guideline concordant cancer care is much lower in this population, meaning that, patients based on their stage are not receiving the, most appropriate and standard of care, cancer care. For instance, surgery rates are low for early stage esophageal and gastric cancers, and patients are not receiving appropriate multimodality therapy for later stages. So all of these factors really drive the poor outcomes in terms of overall survival being much worse in these populations.
And as a practicing clinician, how should one screen for some of these social determinants of health? And do you have any recommendations that when they're identified, what should we do with this information? One of my frustrations is I feel like now we're aware of it, which is great, and we may be screening for these social determinants, which is great. But then how do we connect the dots to actually get people some resources to address some of these vulnerabilities?
No, that's a great point. I think we've, exhaustively, demonstrated the disparities, but we haven't really come up with solutions, to really, positively impact some of these opportunities. One example, there's a recommendation that we should routinely screen patients, for, food insecurity, housing insecurity, poor access to transportation, for clinic appointments, and then provide resources to try to mitigate, some of the impacts of these, areas or these inequities. Another area of opportunity is, getting nurse navigators to help, not only identify these inequities, but also to help patients navigate through the healthcare system, how to, find access to high quality cancer care at a, NCI designated cancer center. So I think that's another opportunity that we can really use to sort of reverse some of these inequities. And then finally, improving communication and trust between, vulnerable populations and clinicians in the cancer space. I think that's another area that has been sort of studied, but we haven't really done much to really move the needle in terms of improving that communication and improving that trust between provider and patient. So I think that's another opportunity as well.
Yeah, that's great advice, and I think a perfect place to conclude our time together today. I really am grateful to you, Dr. Merritt, and you, Dr. Seahawk, for your time today on this podcast, and more importantly, for being guest editors on this volume of Surgical Oncology Clinics in North America. You did a fantastic job amassing just a simply wonderful group of authors, national, international experts on esophageal and gastric cancer. And I know this volume will serve as a very important resource for people who, providers who are caring for patients with these diseases. So thank you both very much again.
Great. Thank you, Tim.
Thank you.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to contemporary management of esophageal and gastric cancer. The 4 articles discussed, as well as 8 others, are in the July 2024 issue, Volume 33, Number 3. The series is available for individual print or online subscriptions. Visit www.surgonc.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter at Surgical Clinics, and you can find our podcast on YouTube, Apple Podcasts, and your favorite audio streaming platforms. Thanks for listening.